Chapter 8. Full-term gestation begins at 38 weeks. Preterm labor is anything prior to 38 weeks and after 20 weeks. Term gestation refers to weeks 38 through 42 of a pregnancy. Remember, these are theories. Labor through the years has become medicalized, and there is a huge push to bring it back into the power of the woman, which I personally believe is very important. Labor is different in every woman and in every pregnancy. Oxytocin is the love hormone. The baby produces cortisol. The placenta converts it to estriol. The bloody show is the mucus plug being released. That burst of energy is called nesting. Sometimes women get this huge urge right before they go into labor to clean the house and clean everything. Rupture of membranes can be spontaneous or artificial if the doctor does it. So that is the waters breaking. It can be a gush, a trickle, or a flood. Usually means labor will start soon. If it hasn't, we get concerned. We want to know, what time did the waters break? What did it look like? What did it smell like? We worry about infection if mom is ruptured too long. Lightning is the baby moving down out of mom's diaphragm. Usually mom can breathe a little easier when that happens. Contractions can be real or false. You might have heard of Braxton Hicks. Those are false contractions. They usually don't cause any dilation and effacement of the cervix, and they usually go away. They're not regular. They go away with activity. So here's a slide that shows you the difference between true labor and false labor. You guys need to be able to recognize the difference between those. Dilation is the cervix going from a closed position with that mucus plug intact to 10 centimeters. Effacement is the thinning of the cervix. Typically it's about 3 to 4 centimeters deep, and it becomes imperceptible, and it is done by the touch of the examiner. It's described as 0 to 100%. We're going to talk about the 7 P's of labor. The passage is what does the baby and everything have to travel through. This is where that gynecoid pelvis comes into play. The obstetric conjugate, that measurement we talked about in previous chapters. This is where all this becomes super important for that baby to get through, right? The pubic bone doesn't move, and we got to make sure the baby fits through. The passenger. What are the passengers? The fetus, the amniotic fluid, the membranes, the umbilical cord, and the placenta. Cephalic presentation is the most favorable for delivery. Most doctors won't deliver a baby in a breech position. The head pushing on the cervix is kind of what helps the dilation and everything. So labor just goes better if that hard head is pushing. Page 110 shows the different breech presentations. Frank breech is the most common. That is when the butt is trying to come out first and the feet are up by the ears. This slide talks about the positions. Understand that the most common is LOA and what that stands for. Left occiput anterior. That is all about, even though the baby's head down, what kind of position is it in? If the baby doesn't have their chin tucked, it can be a big difference for that mom. Attitude. They have attitude before they're even born. So the best is fully flexed with the chin tucked. You can see that on page 111, figure 8.5. Station is where the head is in relation to mom's pelvis. So as the baby's being pushed down with those contractions, we are checking to see how high in the pelvis it is. The next slide kind of gives you an idea of what I'm talking about. Notice the baby's head in relation to the ischial spine. It's a little notch on the pelvis. And when baby's head hits that spot, we call that a 0 station. And then everything becomes a plus number when the practitioners are describing it. And that is when usually they want mom to start pushing. If it's a negative number and the head is higher in the pelvis, we usually want the body to do the work of laboring that baby down. The powers is the next P. The powers are the pushing and the contraction. So we need to understand as a nurse the contractions. The increment, the acme, the decrement, that just describes the increase, the peak, and the going down of the contractions. Terms used, onset, duration, frequency, and intensity. So the duration is how long does each contraction last, beginning to end. This is described in seconds, and we don't want it to last longer than 90 seconds. Frequency is the beginning of one contraction to the beginning of the next contraction. We describe this in minutes, and we would like them to be at least 2 minutes apart. Intensity is how strong is the contraction, and this is just done by touch. The nurse will usually just have her hands kind of on mom's abdomen, and they kind of can tell by pushing on it. The interval is the time in between contractions. This is when mom and baby is resting. We would like that to be at least 60 seconds. So contractions that are more frequent than every 2 minutes, last longer than 90 seconds, and have intervals shorter than 60 seconds. We usually will try to slow them down, unless that head is crowning and the baby's right there. But if mom is pretty far away still, they usually don't want her contracting that fast and that hard. This shows you some tracing. So this first one right here shows you can kind of say it's a mirror image where the peak of the contraction is when the baby's heart rate drops the most. That is called an early deceleration, and that is due to head compression. We don't get too excited about that. This one further down here where it says sudden drop, you can see that the baby's heart rate dropped after the peak of the contraction. That is a late deceleration. Baby and mom should both be resting during this interval, right? So that we would get very concerned about. The position that mom is in is our next P. Hopefully mom can get up, walk around, move around during labor. If she's in the hospital and she's had an epidural, she's going to be in bed because she won't be able to feel her legs and her feet, among other things. But if mom hasn't got an epidural, the more she can move around, the better she is. Changing positions can shorten the labor process. Mom's psyche, where is her head at? We want to make sure mom is staying calm. Childbirth is a memory and an experience a mom will never forget. So as the nurse, you are there to make sure that it is the best experience that she can have. Establishing trust with clear communication will help. Encouragement and praise will help her stay true to her choice of a birth plan if she has it. Explaining what is going on can help keep her calm. Pain management. We want to make sure mom is in as least amount of pain as possible to reduce her anxiety. So we want to follow her choices. There are pharmacological and non-pharmacological methods of pain management that will be discussed in Chapter 10. But supporting the woman's choice is the role of the nurse. We are always advocates for our patients. Encouragement, breathing techniques, massage, and walking are all helpful. Here's a question, here's an answer. First stage of labor. The first stage of labor has 3 phases: the latent, the active, and the transitional phase. You guys need to understand the stages and what is happening in each one. In stage 1 of labor, the first phase, the latent phase, mom's usually pretty happy, she's excited, labor has started, contractions aren't coming too hard yet or too fast, she's talkative. Then we go into the second, the active phase. She might be getting a little nervous. The pain might be getting worse. The contractions are getting closer together. We want to make sure she stays with her birth plan by keeping her calm and hydrated. The transitional phase of labor is often where moms give up on their birth plan. They might be screaming for pain meds. They might be cussing and yelling at people. Again, we are trying to keep her calm and in her birth plan. She should have constant nurse supervision at this stage. Dilation and effacement completes here. So she'll be 100% effaced and 10 centimeters dilated. The second stage of labor is all about the baby. We're going to be pushing that baby out. We don't like this to truly last longer than 2 hours. Because mom can get tired. You know, this just isn't good. You can read about the closed glottis and the open glottis pushing in your book. Closed glottis pushing is the typical one that happens in the hospital where we have mom hold her breath and push for 10 seconds while that contraction is going on. Fetal position changes, cardinal movements. Babies are so smart. If you look on page 116, figure 8.8, it shows you the movements. And this is what kind of baby just naturally does to get out. This also is talking about the internal rotation, what baby's doing. But at the bottom of this slide, it talks about the third stage. So once baby is delivered, we're in the third stage of labor. The third stage is all about the placental delivery. Practitioners should never pull on or try to hurry up placental delivery. We would like it delivered within 30 minutes. Once the placenta is out, we need to check it. We need to make sure that it is intact. They used to send all of them to the lab, but now they just send them if they think, something looks kind of funny or funky. Some moms do delayed cord clamping. Some moms want to take that placenta home. So we need to make sure we're following mom's plan. The fourth stage of labor is all about recovery. There should be someone with mom for the first hour after birth. Hopefully we're doing bonding. Maybe mom wants to breastfeed. We're doing skin to skin. We're doing important things for baby. We're doing APGAR scores at 1 and 5 minutes. We're drying baby off to reduce risk of being chilly. Skin to skin. Hopefully mom's doing it. Lots of stuff going on in mom's body. We need to make sure her bladder stays empty. We want to make sure she stays calm. You might want to read about signs and symptoms of hyperventilation, numbness, tingling. What can we do for mom? If she's lightheaded, she can't breathe, she's breathing too fast, we want to slow her down. We can have her breathe into her cupped hands or a paper bag if we have it, right? The GI system, mom might have got sick, mom might have had a bowel movement during labor. We want to make sure that we always assure her everything is normal. She shouldn't feel bad. This is just all part of the process. We expect moms to lose about 500 milliliters of blood with a normal vaginal delivery, and it's about 1,000 milliliters of blood loss in a C-section. So we are checking mom's blood loss. Lochia is the name of the blood loss right after delivery that happens for about 3 weeks. So we'll be following that. We want to remember that we also have a baby there. We have mom and baby. We got to dry that baby off so they don't lose heat by evaporation. Think of how you feel when you first come out of the shower. You're kind of chilly, but as soon as you dry off, you kind of warm up. And we want to make sure they're wrapped. They have a warm blanket around them. They have a hat on their head so they don't lose heat by convection. We're doing APGAR scores at 1 and 5 minutes. They need to be at least a 7. We'll get into those later in another chapter. But if it's below a 7, we need to be doing some kind of resuscitation on that baby. It's telling us it needs help. Here's another question. Here's another answer.